Thank you so much, Justin, and for everyone for the invitation to be here today for the annual update. As Justin said, I lead the inpatient service over at Mass General, and we admit about 5,000 patients a year to the hospital, cancer patients, and it has been clear that over time we are seeing an increasing number of patients that are admitted with toxicity related to novel therapies. And so today, I'm hopeful that we can go through some of what we're seeing and what's in the literature as well. So maybe we can go over to recognize kind of the various presentations of immune-related adverse events. When do they happen? How long does it take them to recover? And why, right? The underlying, what is actually happening, or what's the mechanism of action? And then we'll go over the proper evaluation and management of patients, and we'll focus just on the serious adverse events. Krista did such a phenomenal job kind of in the outpatient setting, which is challenging, but we're gonna focus a little bit more on the inpatient setting. Make no mistake, this is going to appear to be serious toxicity and a lot of conversation around that one topic. This is rare. And these therapies, on the other hand, are breakthrough therapies. Whether you listen to Justin showing the curves of non-small cell lung cancer patients that are now 15% that are 4 years plus out, or melanoma 30 to 40% that are 5 years plus out, these are changing lives. And so I do think we need to step back and think about the toxicity, but it's definitely not the whole picture. But just as we used chemotherapy for decades, people thought about nausea, right? They continually innovated and thought about drugs to treat nausea, or even neutropenia, thinking about growth factors. So we're really in the game of trying to understand these side effects to better manage them, to keep people on treatment longer and doing better while they are on treatment. So I know that over the last day, you guys now have, your basics in immunology for certain. But I just wanted to step back one more time and reiterate. The entire immune system is really designed to recognize self. What is your own tissue versus non-self? And many times a day, antigens are presented on MHC molecules, right, on the antigen-presenting cell, up to the TCR, the T-cell receptor. It takes 2 signals to activate the immune system. If that second signal does go through CD28, if it is an activation signal, the T cell then proliferates. It secretes cytokines, start to migrate through the tissues looking for more antigen. But it's remarkable. This really is a checks and balances system. It's not like Washington. It's really tightly regulated. And as it goes through within hours, PD-1 starts to come on the surface. And if it lands in areas of a lot of antigen, there is PD-L1. There's ligand that shuts off this system. This is normal peripheral tolerance. This is what's really important for our liver, our heart, our gut, and so on. So we cannot be surprised then breaking this tolerance, right, by using inhibitors may have an effect on autoimmunity. With that said, we don't know the actual underlying mechanisms of each of these conditions, and more work needs to be done. As Krista pointed out, there's a wide variety of conditions that can result. On the inpatient side, over the last several years, we've actually admitted over 600 patients with suspected toxicity, but it's probably more like 320 so that are actually confirmed toxicity to date. In our experience in the hospitalized setting, colitis is about 40% of the cases that we see. And then we have a 3-way tie. So we see about 15% of pneumonitis, endocrinopathies, and hepatitis. Following that is neuro. So the neuro conditions on the inpatient side are about 9% of our cases, and myocarditis, our cardiac, are about 7%. So just to give you the flavor, because it looks a little different than the outpatient setting. And when we think about the incidence, I think what Krista talked about grading is so key. We need to be speaking the same language. And the CTC AE is not perfect, and it wasn't designed for immunotherapy, but it is the best we have to date. And so I think the more that we can record in the admission note, the progress notes, the discharge, the more that we can really see how these patients evolve over time is critical. And if we look at a trial, just looking at grade 3 and 4 toxicity in a trial that had a CTLA inhibitor, a PD-1, and a combo, you can see these rates of toxicity that occur in the trial. I will just say, though, it's complicated because fatigue, grade 3 and 4, is also listed here. There are some people that keep on drug with that level of fatigue, or an elevated lipase of grade 3 and 4. It's asymptomatic, it's not pancreatitis. What do we do with that, right? So I like to look at actually the drug discontinuation rates, thinking about when did it matter enough to stop drug. And if we look, IPI is about 16%, Nivo about 12%, and the combination for 39%. So this isn't rare, but just importantly to note that not all of the conditions cause discontinuation of drug. As Krista pointed out, specifically the endocrinopathies, we keep going, even type 1 diabetes. So when do they occur? She pointed out that a lot of it is within the first 3 months, which is definitely true. Skin tends to be the first, then you have the GI, so the diarrhea or colitis, and later we start to see the liver and endocrine toxicity. That is the same. Again, these are the cases that we've seen throughout the board, so a variety of conditions. We also see that these individuals are presenting relatively early on average within the first 3 months, with combination therapy presenting even earlier. However, I like to go back to this. I'll explain it, but I like to go back. It's old, so 2010, right? But if we think about the pharmacodynamics of PD-1 just in general, this helps us frame the fact that we have to have high suspicion no matter when. And what this is basically time is on the x-axis, so days, and PD-1 occupancy after doses, meaning how long was that antibody still stuck. And if we think about the doses here, they're in little triangles. But it's remarkable to me to see that it's not that after that second dose, within a couple weeks, you go down in terms of your PD-1% occupancy. But even still, over a year out, we have 50 to 60% occupancy. That's why we can't be surprised in these rare cases where even though we've stopped drug, these toxicities can happen long term. And if they're sick enough to be inpatient, you have to have a high suspicion, even though you do know that a lot of them happen early. It just kind of, I think, always helps me frame we're never out of the woods. When we think about the resolution kinetics, or how fast do people get better, our average length of stay is 5 to 6 days. And we actually see improvement, or we wouldn't discharge them, but we see improvement often before they are discharged. But when we think about resolving to baseline, resolution kinetics can vary. So holding immunotherapy is a hallmark, especially for severe toxicity and immunosuppression, as we'll get into. But if we look, the GI toxicity, hepatic and renal, are actually generally very quick, whereas skin toxicity can be longer, and endocrine toxicity can really be permanent, meaning they're needing the hormone replacement for the duration. So the resolution kinetics do vary. Why, right? This, when you're at the bedside and you're frustrated and you're trying to understand what is happening, I think why is so important as we go forward. And the problem is, I thought this annual update I would have some earth-shattering why to explain to you, but I don't. I'm hopeful next year that's different. If we think about the mechanisms of toxicity that have a little data or have been proposed, there's actually a really good review by Hellman and Postow in the New England Journal of Medicine. But is it T cells? Or is it those pink T cells that recognize both the tumor and normal tissue? Is it just increasing level of inflammatory cytokines? Remember, when it's activated, the T cells proliferate, there's secretion of inflammatory cytokines. Is it the fact that the patients were just predisposed in certain conditions to develop, say, myasthenia gravis, meaning they already had the acetylcholinesterase antibodies, and we just dysregulated the immune system enough that they developed the pathological condition? Or is it the fact that certain tissues expressed some of these things, such as the pituitary having CTLA-4 expression? So is it that we just use the antibody, ipilimumab, you have this kind of direct binding and complement-mediated inflammation? We still have a lot to learn, and I'm hopeful maybe in the panel even we can discuss how do we start to move forward with understanding the pathophysiology. So what is the summary so far? Immune checkpoint inhibitors are now standard of care. The field is moving so fast. We had several years where they were single agents, and now already we're getting into the combination era. And I think Dr. Gaynor's question is right on, that we are in a new world and we have to think about frameworks differently. We know that there's a subset of patients with durable long-term responses, that adverse events, as Krista told you, are typically grade 1 and 2, but can be severe and can be fatal. There was a recent review from Doug Johnson out of Vanderbilt. He led a review to look at the fatal toxicities. And thankfully, this is a relatively rare event. So for PD-1 or PD-L1, it's less than 0.5%. For IPI, it ranges about 1% of patients, and the combination is about 1.23%. The only thing I'll say, and I'd love to talk about this as well, is how many patients do we think will be treated with immunotherapy, right? There's one review from Tang that looks like the estimate is that we'll treat 600,000 patients this year. And so if we take 1%, that is 6,000 patients across the country. That's more than CML, right? Chronic myelogenous leukemia. It's more than we will diagnose with one condition. So even though they are rare, I think we really do have to have a high alert as we move forward, just given the numbers of patients that we are treating. We have to be aware of the unique autoimmune toxicity profile and the fact that we have to look for more than one. This is a theme you're hearing in the toxicity talks, but on the inpatient side, about 10% of the time, we see more than one. The problem is it can be hepatitis and aplastic anemia. It can be a colitis and a dermopathy. It doesn't always correlate in the same regard. We will talk about how we're starting to see myocarditis and a myositis overlap happening, but it's not that we can always understand what these multiple toxicities will be, so we have to have broad view when we think about the workup. And the irAEs are often within the first 3 months, but I just told you that the PD-1 hangs on, so it can happen after immunotherapy discontinuation. And importantly, unlike chemotherapy, the nausea got better, the counts got better, you just kind of waited it out. These can last for several weeks or months. The mechanism is not well understood. I feel like this slide, it's not surprising to any of you. It matches the FDA approvals, but it still makes me step back a bit. If we go back to 2010, and this is each year since at Mass General where we work, you can see the really exponential curve of numbers of patients that we're treating with immune checkpoint inhibitor therapy. Last year was over 900 patients. And we can see, too, patterns have changed. So the lighter blue was ipilimumab. That was, earlier on, and now we're using far less of that. We're using some combination, but the majority is in single agent PD-1 and PD-L1. And importantly, it's no longer just melanoma. So these are the melanoma graphs, again, 2010. These are all the years, most recently in 2018. And you can see it is still increasing over time, and we treated over 200 patients a year. But for the first time last year, thoracic has already increased in terms of higher volume than we're seeing in the melanoma clinic. GI is right behind. So we're starting to see now that it's approved in over 15 types of cancers, we're starting to see this change. So it's no longer just in one disease center or two. And last year, I spent my talk talking about this individual case of David McDougall. I'm not going to do that this year because of the fact that I wanted to give you some fresh cases. But I have to say a little bit about David just because of the fact that he changed my life so much and really kind of a career direction. So David was a 65-year-old, so he was a loving husband. He had 2 really successful kids, and he was a CEO of a tech company. He really had it all. They were building their 4th house on Cape Cod, and he was diagnosed with metastatic melanoma. He was one of the first patients in 2016 that we gave double immunotherapy to that ended up on the inpatient service. I met him in the emergency room at Mass General, and he had an oxygen saturation of 48%, which is not compatible with life. And I remember how rocky it was at the beginning, almost nearly needing to intubate him, but we were able, with high-dose IV immunosuppression at 2 mg per kg for the Solumedrol, he really did remarkably improve. In 5 to 6 days, he was discharged, he was on room air. 4 weeks later, though, he came back to the hospital and was admitted. Even on very high-dose immunosuppression, he actually developed colitis related to checkpoint and a neuroinvolvement of the motor and sensory systems related to checkpoint. It was relentless. And we tried infliximab ×1, ×2, a third line of immunosuppression, IVIG, you name it. It felt like we were throwing the kitchen sink at him, and he never walked out of the hospital. And I can remember the day that he realized he might not make it. And he looked up at me and he said, "Doc, whatever you do, you have to learn from this." And I think that's what is still sticks with me today, is the fact that we have a lot to learn. And I've been over this case, a million times, and we did ask his family for autopsy, and what is really remarkable is that there was not one S100 positive melanoma cell. So not one. His disease was eradicated. But he died from the overwhelming kind of treatment actually related to his side effects. So I think we have a lot to learn. David is the rare case, right? Remember, the fatalities are really less than 1%, but it really has moved us at Mass General to think about how do we answer questions so these don't happen again? What is the underlying pathophysiology? How do we best prepare providers? How do we build a team? What are we kind of moving in the direction for? And we mentioned the guidelines, which I think are an incredible resource. And so those are going to be available. Obviously, they're free. The NCCN guidelines was actually just updated in April of this year. And I thought, yes, we're going to see some really kind of major changes in management. But you're not. So it's a 99-page document, and I think, honestly, we're almost walking backwards, and we need to think with the various stakeholders in the room, how are we going to move forward? Because what we've actually went to in the document is a lot of consult blank specialty. And specialists are critical, that's definitely the case. But I went through the document just to see, like, when is the oncology, ASCO and NCCN telling us to consult our colleagues? It's not a matter really what's in black, but the fact that it's so multidisciplinary in nature. And we have to realize these people aren't giving this drug in managing the mild or the moderate, but yet when we get to severe toxicity, they're supposed to help. And so we really have to think about how do we educate specialists across the board. And so that's what we did. We sat down at Mass General and kind of wrote out the wheel of who do we need. We knew we needed disease-specific specialists within oncology, so not just melanoma and thoracic, who have really seen the most patients, but also we need to pair that right alongside with our head and neck doctors, our breast cancer doctors, GI, and so on. And then across the wheel for the Department of Medicine, you really need all of them. So renal, rheum, and outside of the Department of Medicine, you need derm, optho. So we kind of tried to come together as a group to learn more, to clearly be involved in the clinical care, which is important, but to be involved in the clinical research aspect, because we have to know the phenotypes. What are we actually looking at, and are there clinical predictors for these toxicities? And then tightly linking with Dr. Vellani, who's also at MGH, and her lab, really thinking about leading our translational effort. So can we find better diagnostics? Can we think about better targeted therapeutic solutions? So Dr. Vellani has a whole lab here that you can see. And what's, I think, really fun about the makeup is that it's fellows from across the department. So we started with a rheumatology fellow and a GI fellow, and have expanded now. We have cardiac fellow, endocrine fellow, and onc fellow is joining. So it really is trying to teach individuals how to see what they're looking at in the clinic and manage it, but also then how to take those samples and think about the basic science aspect. It gives that kind of full bridge for them to see. And I will just point out, Dr. Lede Thubetti is also here, and she is a clinical immunotherapy toxicity fellow. It's not ACGME accredited, but we need to be able to teach other individuals how to run these types of programs and see these types of patients. So she is here on her second-year fellowship from Spain and is really the critical piece on both the service and in the lab. And the other part is education, right? So when we think about the people that see these, it's the people in the emergency room, it might be nurses, nurse practitioners, this is a wide variety of providers. And so we come together every 2 weeks to think about a case conference, and we go specific toxicity by toxicity. And you can see derm, renal, neuro, each of them. And we talk about the cases, the challenges, what our algorithm is to manage them. And then we save these so that people can access them when they have availability, so that it goes to the nurses and the trainees and the hospitalists. So that's one idea to consider education in your own unique networks too. So there's been a rapid expansion of the use of checkpoint. We saw that. IO is now approved in 15 different types of cancer and even all MSI-high tumors. Serious adverse events can involve a wide range of organ systems, and there's recognition that we need disease-specific subspecialists, and we have to work together to think about how do we develop expertise to recognize these adverse events and educate not just MDs, not just nurses, not just MPs, but all across the board. And so now when we get into the cases, so I think it will be kind of the most instructive to really walk through the individual cases together. And if we think about that same review article that looked at fatality rates, I will just mention they also grabbed 7 different academic centers together, and they said, what is the fatality rate for large academic medical centers for these patients? And it was about 0.6%. But really interestingly, half of that was made up of cardiac and neurotoxicity. So those really are 2 of the ones that kind of plague us most. And I was just speaking with a physician at Toronto, and he recalled a myocarditis case almost instantly that was so challenging to manage. So I think we, for those of us on the front lines, we've seen it. So let's take a 66-year-old female. She was actually relatively healthy on no medications. In 2013, she had a melanoma, so it was a cutaneous melanoma that was resected. And at that time, she was actually treated with interferon. She had a recurrence 3 years later, multiple pulmonary nodules and liver mets. And she was treated with single-agent PD-1 inhibitor in April of 2016. Within 30 days, she came in with left-sided chest pain and shortness of breath. Now, this is quite symptomatic, and in a 66-year-old female, what do you think of first? You always have to rule out acute coronary syndrome, right? That's got to be high on your list when anyone comes in with chest pain. So as fast as she could, she was hooked up to the EKG leads, and labs were drawn for a troponin level. Her EKG was normal. So there was no major ST changes, no T-wave inversions. It was actually remarkably normal for her EKG. It was interesting, though. Her cardiac enzymes were elevated. This was, of course, done in the context of the fact that she had a chest CT to rule out PE or any pulmonary process causing the shortness of breath and chest pain. And it was really the troponin level was the abnormal value in her care. So it was 0.3. This was before our high sensitivity troponin, which is only making things more confusing, but 0.3, and that was on day 1. She actually resolved her symptoms without major intervention, but we had this 0.3. Along with the acute coronary syndrome, you have to think about what are the risk factors, and can you get away with a cardiac CT to rule out calcification to make sure you know you don't have significant CAD, or do you need a cardiac cath? And that really is in concert with cardiology. That's why to the right here, I have a picture of Dr. Tom Nealon, who is our cardio-oncologist at MGH and really has been leading the field in this arena. And so all of that was ruled out, but she didn't get better in terms of troponin. Day 2, day 3, day 4, day 5, we are watching her. In 2016, there wasn't a lot that we knew about this condition, but nobody could understand why her tropes didn't fall. She didn't have demand, there was not ACS. On day 5, her oncologist, outpatient oncologist, said, you know, we're using these new PD-1 inhibitors. It's only been 2 doses, but it is a possibility that this is inflammation related to the heart. So at that time, steroids were started, and Tom Nealon was like, what? Because we don't use steroids for viral myocarditis, and how is this all going to play out, right? This was in the early days. And so steroids were started. Again, she was asymptomatic. You can see that her troponin did go down. She developed a few PVCs, but she did not have major arrhythmias. Because of the PVCs, a beta blocker was started, and then we continued to watch her. We continued, you can see day 9 all the way to day 19. The lady's walking around, but every day we see a troponin that is abnormal and concerning. Not knowing what to do, on day 19, a cardiac biopsy was discussed. This was early 2016. She had a preserved ejection fraction. She was asymptomatic. She was hemodynamically stable. There was not an interventionalist in the house that was going to touch her with a cardiac biopsy. In fact, when we think about cardiac biopsy, so the really scary risk, like the RV puncture, is less than 1%, but it's present. There is a 6% overall risk, though, by the time you think about going into a transient arrhythmia like a right bundle or having a hematoma at the site, things along those lines. So discuss cardiac biopsy. Tom wasn't really convinced, and neither were the interventionalists. She clinically appeared well, normal EF, no signs of heart failure, and no arrhythmias. She was discharged on day 20 with steroids and a beta blocker and a close follow-up. She was found dead at home on day 25. No autopsy was performed, but the very big concern is that she had cardiac arrest, likely related to potentially even an arrhythmia. And so this shocked us into a completely different mode. And Tom, since then, has been involved in a considerable number of cases, and I'll even talk about the literature that's published. But the clinical presentation here is not ileoated, but it's isolated. Sorry for the typo there. But isolated troponin elevation alone. We've seen cases where it's just trope elevation. Or other cases, when I say grade 3, 4 fatigue, I always wonder, what was the workup? Because the clinical trial doesn't show you what was done. But are those cases that actually may have underlying more severe events? Syncope, palpitations, or arrhythmia, we've seen florid CHF, even a STEMI that didn't have a blockage, shock, cardiac arrest, but that isolated trope elevation can be very challenging. The exam can be rock solid normal, or we may have, signs of either hemodynamic instability or congestive heart failure with an elevated jugular venous distension, pitting edema. You can hear a murmur, you cannot hear a murmur, you can have an irregular rhythm, you can have a sinus rhythm. So it is really challenging on the clinical side. The workup, at the heart of it, ruling out ACS, PE, going through all the normal processes, it has to be done. Troponin is important, EKG, BNP, echo. I'll show you how none of them really help. Consideration of a cardiac cath, like I just said, or cardiac CT. Cardiac MRI we'll talk about. The viral panel, we've sent it. We've sent a lot of it. Looking for Coxsackie, adeno, intravirus, EBV, CMV, HIV, never seen a positive, but just kind of looking at, are there other reasons of myocarditis? And then we're going to talk a little bit about cardiac biopsy when necessary. So here's Tom Nealon's paper published last year, and I think it's really worth a read. So when we think about this is 35 cases that he's collected in the registry. They're now up over 100, and a lot of the same principles are still holding true. But they present early. Remember how I told you that our case was presented 1 month after? The average is 34 days. The EKG is abnormal in his study 89% of the time. I would say abnormal for a cardiologist, because 61% of the time it had sinus rhythm. And I'm telling you, they may be seeing slight elevation in certain intervals, but 61% of the time the EKG looks perfectly fine. And so I think that these EKG changes are very subtle at times. And so you're not going to get a clear right bundle or a clear arrhythmia or a VT every time, and that's kind of the point. For troponin elevation, 94% are elevated, and that's really the hallmark here. And it matters how high the troponin is elevated. So there was something in the study where they looked at the very serious adverse events called MACE, major cardiac adverse events. And when they looked at the MACE rate, these are really serious, like needed a pacemaker, developed shock, died. So very significant cardiac events. 46% of the cases developed MACE. So 46% really have a bad outcome, and that's why we have such a high alert. When we look at the troponin, if it was up over 1.5, you had a 4 times risk factor for developing MACE. So it is probably the level of troponin matters as well. Echo, you can just flip a coin. 50% of the time you're going to have a low EF, 50% of the time you're going to have a preserved EF. So again, not helpful. You can have a normal EKG, you can have a normal echo, you can have an elevated troponin as the only thing. BNP as well can be positive some of the time, but it's hard to interpret. And then you might say, okay, well, we have cardiac MRI. That can be kind of the gold standard test for myocarditis. which it is. The problem, 30% of the cases that had a cardiac MRI here, there were negative cardiac MRI, but such strong clinical features that the patient was biopsied and had myocarditis. So 30% of the time, the cardiac MRI can be negative. That's not a test that I trust very much. And then when we do see late gadolinium enhancements, I go to Tom Nealon and I say, you know what, I see it, okay? I'm pretty confident. And he's like, well, the only problem though is that just shows inflammation. It doesn't show acute, meaning you can have previous inflammation that is not necessarily acute and consistent with your case. So we have biopsied in the area of positive cardiac MRI, and it has been negative to rule out myocarditis. I know this is not helping you feel any more comfortable, but I just want to say if you're struggling, we are too. And that's why I think that better diagnostics is really critical for all of us to be able to manage patients. The hallmark is still the pathological biopsy at time of cardiac biopsy, and it looks like acute allograft rejection, like patients have had a transplant and there's actual rejection. You can see here all these blue cells over to the right, so it's a diffuse lymphocytic infiltrate. And there were 2 cases presented in the New England Journal of myocarditis early on, and they had this lymphocytic infiltrate in the parenchyma of the heart, in the AV node, in the cardiac sinus, so it's actually quite a diffuse process. We learned that steroids at 1 to 2 mg per kg, which is absolutely appropriate for so many of the adverse events, in serious myocarditis, when 46% of people are developing these serious outcomes, we honestly have escalated to think about more transplant management, cardiac transplant, and they use 1 gram of Solu-Medrol daily, and that's how we start. And we discuss further immunosuppression depending on biopsy results. We've tried infliximab, we've tried Cellcept, ATG, you name it. We've had kind of a wide range, and we can't give guidance at this moment on exactly what you should escalate to, and I think that's the most unsettling, but clearly a lot of work to do. And then having a high suspicion for another irAE, because over 50% of the time, the myocarditis patients actually have a second irAE. And we're seeing an overlap occasionally with a myocarditis, myositis, so inflammation of the muscle, and myasthenia gravis, so neuromuscular junction involvement. And I have learned a whole new review of systems that if you take nothing else away from this room, I would love you to think about the review of systems in patients that you see fatigue, in patients that you see short of breath, in patients that you see myocarditis. And what that looks like are, do you have any eyelid droopiness? Do you have any blurry vision? Meaning, is there any kind of diplopia? Is there any issue with ptosis? Do you have problems swallowing? Or do you have problems speaking, meaning is your speech off? Dysarthria and also dysphagia is bulbar involvement. Do you have problems breathing, meaning shortness of breath? Because you can get neurological, neuromuscular junction involvement of the diaphragm that is causing the shortness of breath when you cannot figure out anything else. Do you have weakness, and is that fatigability, meaning does it fatigue throughout the day? So this neurological symptoms where you're looking at vision, where you're looking at droopy eyelids, speech, swallowing, shortness of breath, and weakness, because we're not trained in medicine to really recognize all of these other neural conditions. And so I really do feel like a full review of systems is kind of critical in that aspect. And we can talk more about that in the panel as well. So case 2, 67-year-old woman, so melanoma, this is a happier case. So melanoma of the right eyelid, and unfortunately also had recurrence to lymph node and lung. So she started with PD-1. So she started with pembrolizumab, but progressed after 4 cycles. And then she went to a CTLA-4 inhibitor. So then she went to ipilimumab. And she developed this inability to eat a normal diet and weakness for months. A slow downward decline for months. And if we had to track it back now that we know in hindsight, it actually started with pembro and then kind of escalated on ipilimumab as well. Inability to eat, remember the review of systems, one of the most important is swallowing or dysphagia. So her past medical history, so she had alcoholic cirrhosis, epilepsy, diabetes, hyperlipidemia. Honestly, although epilepsy, you might be like, okay, that might be a crux. Here it is actually not. She was on medications to treat these conditions. So she was on a statin. She was on 2 drugs for her seizures, as well as metformin and Lantus. So we know we have dysphagia so much that she really cannot eat solid foods any longer. But there was no dyspnea. There were no numbness or tingling. There were no bowel or bladder issues, no ptosis or diplopia. The differential diagnosis for someone that can't eat, that has widespread metastatic disease, is kind of diffuse. So whether or not you have esophageal conditions have to be thought about. Regular spasm, whether achalasia or obstruction is something pushing on it. Imaging becomes important. But why we're talking about this case is because this whole spectrum of myopathy, meaning muscle involvement, versus neuromuscular junction, like myasthenia, versus really just nerve involvement associated kind of with dysphagia, is something that's the spectrum where you have to tease out if everything else was negative. And so in her, the CK was not even helpful. The CK was negative. But we had Amanda Geaton, she did an EMG, and it didn't look typical for any exact location, meaning it's really hard on EMG to always localize to whether you're dealing with muscle problem, nerve problem, or neuromuscular junction. And she's finding in these cases it's even more atypical than her regular presentation. So a muscle biopsy was performed, and this is in a normal CK patient with myopathic changes with a chronic inflammatory infiltrate. It looked like immune checkpoint inhibitor-related inflammatory myositis. So she was treated with IV Solumedrol at 1 gram times 3 days, followed by prednisone, and by the time she left the hospital, NG tube out, she was up walking again to clinic and able to eat a normal diet. But this is a whole new world for us to have a CK negative inflammation of the muscle. I'm sure that one didn't make you feel any better either. But the reality is that we're working on this together. So thankfully it's rare. The reported incidences you can see here for the grade 3-4 toxicities are actually quite rare. We do worry they might be underdiagnosed because people just haven't picked them up, or that we might have an issue where we don't have great diagnostics. And we like to try to bucket them because the nervous system, the neurological irAEs, can span both the central nervous system, so it can be brain, encephalopathic, kind of encephalitis, myelitis, spinal cord, as well as the peripheral processes that we've kind of been talking quite a bit about. And the kinetics are generally early, so they're more in the 2 to 6 weeks of therapy that they present. And our patient had a muscle problem, right? She had myositis. But when we think about that altered mental status or issues that make us concerned for encephalitis or meningitis, we rule out disease. It's really important because it can be subtle, right? MRIs are critical to see and make sure that you don't have metastatic issues, as well as an LP to rule out leptomeningeal spread. And then the same, you go back to kind of the general workup of ruling out infection is important. EMG has been a helpful test, but oftentimes is non-diagnostic. And then we think about the other, based on the presentation of the patient, thinking about looking for oligoclonal gammopathy for MS-like condition, or paraneoplastic panel, or acetylcholinesterase, those things that might be associated with myasthenia. The management is often still high-dose steroids, even in Guillain-Barré. Guillain-Barré is typically not a condition where you want to give steroids, so this close interaction with neuro is important, because I've seen anything from IVIG to plasmapheresis. We just don't have a great cookbook in this setting. And then it looks like we hopefully will be able to get through our last 2 cases. Okay, so case 3 is a 65-year-old patient with metastatic melanoma, and he had a past medical history of prostate cancer. That was fine, depression and hyperlipidemia. He did have radiation to the brain and spinal cord as well, and had been on previous therapies, because this was in the early days, so had been on previous high-dose IL-2. And he started on a clinical trial with dual agents, so CTLA-4 and PD-1, so we have combination. So I think you probably know where this is headed in terms of a non-productive cough, dyspnea on exertion, and pleuritic chest pain. He had ground glass, kind of these classic ground glass opacities. As you can see, all of this hazy material here, but it's quite diffuse, bilateral, involving multiple lobes. So when we think about the clinical presentation of pneumonitis, I bring this up because this is 15% of the cases that we see on the inpatient side, and it can be hard to rule out. These patients have potentially had radiation before. They have, multiple reasons, even disease that can be challenging. So working through that differential is important. About half of them come in with shortness of breath. You can have a variety of other symptoms, whether that's cough, fever, chest pain, but the problem is 30% of them are getting their regular scans, and you start to detect pneumonitis, and how do you kind of work through that? The incidence can be as low as really single-digit percentages, up to 10% with combination therapy, but there was a recent, that Journal of Thoracic Oncology paper last year by Suresh actually indicates that the real-world incidence may be higher, upwards of 19%, so something we're going to face. The differential we walk through, kind of infection, is it any kind of pneumonia? Disease, is it any kind of lymphangitic carcinomatosis? Of course, it'd be cardiac. I already told you that we think about myocarditis in these patients anyway, or some of them just have underlying heart disease. So is it edema? Is it COPD? Is it alveolar hemorrhage? Or is it effusions? Really, you kind of try to rule out everything you can before we get to the diagnosis in parallel. But I would just say we need to consider sarcoid. So there is a recent paper that looked at sarcoidosis, and it might be upwards of 7% of patients, which is really fascinating because sarcoid also lights up on PET scan, right? You have increased lymphadenopathy, and so it may play into even that thought of, do they have progressive disease or not? And sarcoid can affect a wide variety of organs. If it's biopsied, it's that classic kind of granulomatous material. Sarcoid does, like other of the irAEs, need immunosuppression if it's involving important organs and causing symptoms. So sarcoid just has to be on the list for more than one thing. And when we work it up, we know it's a diagnosis of exclusion. The bronchoscopy decision is important. Anytime that you're thinking about a patient, if you're concerned at all for infection, that bronchoscopy does help rule out infection. In addition, the patients with pneumonitis tend to have a very lymphocytic predominant BAL, even a little eosinophilia, and so that can kind of help you working with your pulmonologist. I will say in our case, it's actually, we have to push more often, and I think a lot of that has to do with just trying to when you have the right imaging with the right clinical criteria. The imaging is tough, and oftentimes we have to sit down with an experienced radiologist because this, of course, when you see that kind of ground glass, like the typical one, that's actually a little bit easier, but it can look like cup-like, it can look like hypersensitivity, it can look like a pneumonia, even a locked-in kind of lobulated area, and so it's not always so easy to interpret what pneumonitis might look like on CT scan. And when we look at kind of the grading, so Krista talked a lot about outpatient management, and thankfully for pneumonitis, the grading, typically the cases are lower grade toxicity. But when we see that it involves all the lung lobes, like in my case, or over 50% of the lung parenchyma, it really gets down to kind of grade 3. And at that time, we co-manage, so we hospitalize, we do IV antibiotics and IV steroids together, consider that bronch, and the important thing is escalate immunosuppression in 48 hours if they're not improving, because unfortunately the people that are refractory for pneumonitis have very poor outcomes as well. Now, the steroid refractory disease, you will probably say, well, what do you use? What do we use? And the problem is we have also used a variety of different second-line agents, but we don't know why we're using them either. So infliximab, Cellcept, IVIG has been used. The first clinical trial to come out really for adverse event management is coming out of Hopkins. Dr. Naidu is looking at a clinical trial for refractory pneumonitis. Again, it's though pretty rare, but refractory pneumonitis looking at infliximab versus IVIG. I'm a little disappointed that we can't look at kind of a broader subset of immunosuppression along with correlative science. So we still have a way to go in this field to really make sure that we are thinking about the agents to give you guys a better annual update next year. And then this fourth case, I promise I'll be quick. Oh, I have 1.5 minutes. I better be really quick. So 55-year-old female, we'll kind of make it short, but a lung cancer patient that came in with fatigue, nausea, vomiting, polyuria, polydipsia, polyphagia, really looked like a classic kind of new onset diabetes. And she was found to have a blood sugar of 499 and an anion gap of 30. The problem was that in the clinic, it's not as easily recognized that this is very serious type 1 diabetes with newly forming DKA. In fact, for this patient, we didn't even have a blood glass till day 2. We didn't have any kind of serum ketones to look our urine ketones. So I think that we're just not used to. Can you just raise your hand if you've managed a type 1 DKA case in the last 3 years? We got a couple, so you could just call them. This one was yours. No, I'm just kidding. It wasn't. But the issue is that it's now something that I think we're going to have to start to interact with a little bit more. And it was diabetic ketoacidosis secondary to new type 1 diabetes. So things to think about. IV hydration are critically important. And right before insulin, so if you're thinking about insulin in the outpatient setting in a new DKA, we really have to go back to the basics of potassium, and you have to know your potassium first and work closely with an endocrinologist if you're not comfortable with that, because the last thing you want to do is bolus the insulin, shove all the potassium into cells and have a hypokalemia that is refractory. So I think that this is only 0.2% of cases, but we do worry about just the recognition of this in terms of anyone that has a higher glucose level in the clinic, and thinking about what is the anion gap, what is the kind of serum ketones, what are the ketones in the urine, and how do we make sure that they're not in DKA. So let's wrap up there just so you have time, and then we can at the panel talk a little bit about how we need to approach this in a broader context.
That was fabulous. I know people probably have lots of questions. I know we also have a panel. Maybe we can take one question now and then save the rest for the panel. Or if you want to go to the mic.
Hello, I am Muralidharan Chellam. I'm a fellow in medical oncology. I'm coming from Toronto. I had earlier spoke to Dr. Reynolds about this case. I had a patient, 84-year-old lady, diagnosed metastatic melanoma. After one dose of pembrolizumab, she was diagnosed with this myocarditis. We first tried with the high dose, steroids, because the normal dose not working. This 1 gram of solimedrol. Then she had some response, but then the troponins continued to remain elevated. Then we started infliximab. Then we also added CellStep. Nothing seems to be working. But the only thing was we were thinking of biopsy, but the patient and family, they were reluctant. So my question is even if you do a biopsy, how is it going to help?
Yeah, so that's a really good question. The interesting thing is extrapolation is difficult and we need to use caution. But if we look at the cardiac transplant literature, not CTCAE grading, but cardiac transplant rejection has its own grading system, grade 1, 2, 3, and so on. And they vary their management based off the degree of lymphocytic infiltration and the degree of rejection. And so they start with high-dose IV steroids, but they escalate based on that biopsy to things like ATG, antithymocyte globulin, which is going to probably ruin your whole anti-cancer effect, but you have a patient that obviously was quite sick. So the reason why it might help is because and again, this is a lot of extrapolation, so I think we need to study this in broader context, but the concept is if we mirror that and it's a serious, severe rejection, we would think about even higher agents like ATG.
Oh, yeah, this lady, she was not quite symptomatic when she got admitted. Later on, the symptom mostly was fatigue. So in that case, giving ATG, can we give it without any biopsy or just give ATG?
Sure. I mean, you can always kind of treat without biopsy. It's just the issue of kind of in the bigger context, if you've ruled out everything else, this gives us some degree of confidence that at least it is myocarditis. It's not going to, in that case, if she was still so refractory, you can try these other clinical maneuvers. It's just hard to know what you're actually treating. The only thing is, what you're bringing up is that a biopsy underneath a microscope that's stained is not still telling you what cells are there or what you have to treat. And so I think that, we do recommend biopsy when we get to that degree, again, for diagnosis. But did you have a cardiac MRI or did you have any other?
We had all the panel.
Was that positive?
Yeah, only the cardiac MRI was suggestive there is probably myocarditis.
It did. So there are times we don't always go to biopsy. So if you have the right clinical characteristics along with that positive cardiac MRI, we don't biopsy everyone either. So I think that did your patient do well?
Is there any role for tocilizumab?
Tocilizumab, IL-6. I don't know, So there's actually in that same slide deck at the end, you'll see there's actually a whole paper looking at tocilizumab on a wide variety of immune-related adverse events, but we just don't understand the underlying mechanisms to say why an IL-6, agent might be helpful. In CRS, cytokine release syndrome, second to CAR T, we have that data that shows what's in the serum, but I think more study needs to be done.
Okay, thank you.
And then the tricky part is you throw all those drugs on her and you actually don't know what worked. So that's also a challenge.